Organizers. So, good afternoon, ladies and gentlemen. The topic seems to be a little bit complicated. Just read the first line, one molecule, many wins, that's enough. No need to read sugar, scales, organs and lives. The first two words speaks volume why we are discussing Ozempic this evening. Remember, this molecule became the blockbuster drug before it was launched in India. If you start from the story of Hollywood to Bollywood, from Karan Johar to Vidya Balan, from Elon Musk to Serena Williams, Ozempic has today hit the market. There has to be certain reason as to why people across the world looked at this molecule. As you all know, in 2016, the first cardiovascular outcome trial with semaglutide, named as a Sustain 6, showed 26% reduction in the composite of 3-PMEs, largest ever by any anti-diabetic drug to reduce the composite of stroke, MI and CB death. Predominantly due to reduction in stroke by 39%, no drug in the past has ever reduced stroke by 39%. None of any antihypertensive drug, statins or any molecule, any pharmacological agent in the past has reduced the stroke, the relative risk of a stroke by 39%. This is the reason as to why the Ozempic, did not look back. It's not only a matter of body weight and HbA1c. Your patient may have a well-controlled diabetes, well-controlled blood pressure, and yet he died of the heart disease or kidney disease. There is no point treating diabetes. Today we have shifted our gears from numbers to preventing complications. You may have a patient with a uncontrolled diabetes, surviving longer than someone who has a controlled diabetes. So the tool matters now. Those era has gone that regardless of the drug you use, you need to bring down the HbA1c target. Today we need to bring down the HbA1c target with a molecule which has a potential to protect heart and kidney. And therefore, Ozempic, since 2016, after the Sustain 6 trial, never looked back. This is an over-sponsored, presentation, but I have got my own slides to tell you. Dr. Santosh spoke about the glucose lowering ability and body weight lowering ability of Ozempic. I will go beyond HbA1c and body weight lowering. So I will take back this slide which Dr. Santosh presented, but I will emphasize here on the Himalayan evidence created by semaglutide injection 1 milligram. You can see there are 17 randomized controlled trials done with injectable semaglutide 1 milligram, of which you can see there are 7 orange color trials in front of you, which is a head-to-head trial done with injectable semaglutide with other comparators, including SGLT2 inhibitor, including DPP4, including other GLP-1 RA, including insulin. And in these 7 head-to-head trials, semaglutide beats all active comparator, including insulin. This is surprising. And I will not bore you. In one slide, I will tell you the data. If you look at the 2 green slides, green colored studies, lower down, Sustain 6, I spoke about a cardiovascular outcome trial and the FLOW trial, the only trial at the moment done with any GLP-1 in patients with CKD was with injectable semaglutide. And semaglutide shown a significant reduction in composite of hard renal endpoint. And I will go into little detail. So let me take into those 7 head-to-head trials. These are the data in front of you. Very simple understanding. If you look at the match happened between injectable semaglutide versus other active comparator in the 7 head-to-head trial, that includes trial with sitagliptin, with SGLT2 inhibitor, with other GLP-1, as you can see, dulaglutide and Novo's on liraglutide, or AstraZeneca's exenatide LAR, or with Novo's on Novorapid insulin 3 times daily. In all of the trial, in all these 7 head-to-head trial, injectable semaglutide beats all other active comparator outrightly, be it HbA1c, be it weight control. This is a reason as to why we need to look at this molecule back, how this is happening. What is most interesting to know, if you look at the Sustain 11 trial, in Sustain 11 trial, 3 injections of insulin is part given in a background of basal insulin. So basal bolus regime versus 1 injection of semaglutide once weekly with 1 basal insulin beats 4 injection of insulin. Needless to say that body weight lowering will be better with semaglutide, but even with a HbA1c lowering, semaglutide beats 4 injection of insulin, whose dose requirement was infinity, but for the semaglutide dose was fixed at 1 milligram. This is amazing to believe that a 1 injection, 1 milligram of semaglutide can beat 4 injection of insulin in a head-to-head trial. And that was astonishing to me. Now, if you look beyond glucose and body weight control, as I said in very beginning, today control of diabetes is no longer the HbA1c control. If you can't protect, if you can't prolong the life of your patients with diabetes, it is useless to treat diabetes. So we need a drug that has a potential to prevent cardiovascular death, the ultimate cause of death in people with type 2 diabetes, or patients developing chronic kidney disease. The semaglutide is the only GLP-1 which has been tested in patients with established cardiovascular disease and in patients with established kidney disease with the flying colors. None of the GLP-1 has got this data at the moment and even in the future, because if you look back at the trials which is currently under progress, I don't think in the next 5 years down the line we would get another GLP-1 to have a similar kind of data which Ozempic has already established through 2 dedicated trials, Sustain 6, which was a CB outcome trial, and Flow in a patients with chronic diabetic kidney disease. So let me quickly take you through. This is the result. As you can see, 26% reduction in 3-PMS and 24% reduction in hard renal endpoint, not the macroalbuminuria protection. I will come into little detail to tell you that how Flow trial was different from the previous trial of GLP-1, like in LEADER trial with liraglutide or with REWIND trial with dulaglutide. Both of these GLP-1 also shown reduction in renal event, but that was primarily derived from reduction in albuminuria. In the Flow trial, albuminuria was not included in the primary objective of the hard renal endpoint. And yet there was a significant reduction. So I will come back in little detail. So let me start with the Sustain 6. Way back, 10 years back in 2016, patients were randomized to Ozempic 0.5, 1 milligram. Ladies and gentlemen, let me tell you, this is the only study where 0.5 milligram was studied separately. If somebody, many of my friends ask me, do you have data with Ozempic 0.5 milligram? Yes, this is the only trial which has generated evidence that even a small dose of 0.5 milligram Ozempic can reduce the cardiovascular endpoint. So as you can see, in this head-to-head trial, dedicated CB outcome trial, comparing 2 different doses of semaglutide, Ozempic 0.5 and 1 milligram versus placebo, similar looking like pen of 0.5 and 1 milligram, there was a 26% reduction in the composite of non-fatal MI, non-fatal stroke and cardiovascular death. And if you look at what actually derived this 26% benefit, this is the original New England Journal of Medicine paper. You can see this was primarily due to reduction in non-fatal stroke by 39%. As I said, never ever achieved with even any anti-hypertensive agents when it comes to lowering stroke. Now what is interesting to note that in Sustain 6, the combined data of 0.5 and 1 milligram was pulled, but we do have the evidence to look at whether 0.5 and 1 milligram did separately in cardiovascular endpoint. So I took out this data from the original Sustain 6 paper, and you can see 2 different doses on cardiovascular endpoint. On the left hand side is the 3-PMS, and if you look at what happened with the 0.5 and 1 milligram individually of semaglutide, it is not surprising to see here that 1 milligram was actually giving the larger benefit when it comes to composite of 3P MES, as you can look here. But if you go into the right-hand side, what contributed best to the stroke outcome, you would be surprised to see that even 0.5 milligram of semaglutide was giving a larger amplitude of stroke reduction compared to 1 milligram of semaglutide. Sometimes it happens in clinical trial. Similar was the story with the empagliflozin 10 milligram versus 25 milligram in IMPAREG outcome trial. Same story happened in the canagliflozin canvas program with 100 milligram and 300 milligram canagliflozin. Sometimes lower dose even gives you a robust benefit. Not shocking to see that here even a 0.5 milligram is giving you a similar cardiovascular benefit as of 1 milligram. So that's the data of the two different doses. The next question is asked that SUSTAIN 6 was a trial which was done predominantly in people with type 2 diabetes with established cardiovascular disease. If I get a patients with diabetes who don't have established heart disease, can semaglutide gives a similar benefit compared to those having established cardiovascular disease? And answer is absolutely yes. Regardless of whether you have got a background heart disease or not, as you can see in SUSTAIN 6, 23% of the patients were a primary prevention cohort. They didn't have established cardiovascular disease. Rest 67% patient, 77% patients had established cardiovascular disease. But if you look at the endpoint, on your right hand side, if you look at the p-value of interaction, there was no difference between primary and secondary prevention cohort in the SUSTAIN 6 trial. Thereby meaning that regardless of the background established cardiovascular disease, if you have got a high cardiovascular risk defined by any one CV risk factor beyond diabetes, it can be hypertension, dyslipidemia, obesity, albuminuria, family history of heart disease, left ventricular hypertrophy. If you have got any one risk factor, smoking, and if you are patients with type 2 diabetes, GLP-1 is going to help as far as cardiovascular risk reduction is concerned. The next one to go and the unique one to go was the FLOW trial done in patients with established diabetic kidney disease. And again you can see here Ozempic 1 milligram fought with the placebo in patients with established kidney disease. And if you look at the primary endpoint, there was a 24% reduction in the composite of kidney outcome, which this endpoint did not include albuminuria, unlike the LEADER trial or in REWIND trial. In LEADER and REWIND, these were a cardiovascular outcome trial. The renal endpoint were only exploratory endpoint. These were not a patients with established kidney disease, unlike FLOW trial, which was done in people with established diabetic kidney disease, where the renal endpoint was the primary objective, not secondary, tertiary, or exploratory. And as I said, albuminuria was a separate secondary endpoint. It was removed from the primary endpoint of a hard renal endpoint, unlike LEADER and REWIND trial. And despite removing albuminuria as one of the endpoint in the core primary outcome, there was a 24% reduction in the composite of renal endpoint. Now, if you look at the albuminuria as one of the secondary endpoint, there was a 32% reduction in progression from micro to macroalbuminuria. So this data is clearly there. And what was unique in the FLOW trial, this is the only trial in the planet where you get both mortality reduction, be it a CV, be it a all-cause death. The only trial done with GLP-1 or SGLT2 which showed reduction in both CV death and all-cause death is the FLOW trial, as you can see in the FLOW data. And needless to say that there was 65% slower loss of kidney function. That translates into that your patient will no longer require any dialysis or renal transplantation for the next 5 years. So you prolong the life of your patients with diabetic kidney disease by another 5 years, not requiring any dialysis or renal transplantation. And as I said, this is the only trial with both CV and all-cause death reduction. As you can see, 29% reduction in the cardiovascular death and 20% reduction in all-cause death. Remember, ladies and gentlemen, if any drug lowers death, that's the ultimate endpoint. If the drug has the ability to prolong your life by reducing cardiovascular death or death due to any cause, which we call as an all-cause death, then it is the drug for longevity, as simple as that. And as I said, the flow was the only trial that shown both CB death reduction. So semaglutide really offered a wide range of benefit. And remember, this is only 1 milligram. Now, if you extend from 1 milligram of diabetic drug to become an anti-obesity drug to 1.7, 2.4 milligram from Ozempic to Wegovy, then there is a further larger, wide scape benefit. Now, if you increase the dose from 1 milligram to 1.7 to 2.4 to now 7.2 milligram. Remember, now semaglutide is currently under US FDA hammer to get 7.2 milligram dose. I often see in different hall people comparing tirzepatide to semaglutide through the Surmount 5 trial. Remember, when you are using tirzepatide, it is 15 milligram, and you are comparing 2.4 milligram of semaglutide, which is a 6 times lower dose than tirzepatide. Needless to say that the body weight reduction will be larger in the larger dose. So this is not surprising that tirzepatide 15 milligram lowered better weight loss compared to semaglutide 2.4 milligram, which is 6 times less dose. But once you do a trial with a higher strength of semaglutide called a step-up trial with even 7.2 milligram semaglutide lowered body weight similar to tirzepatide in Surmount 1, you can see in your left-hand side 21% reduction with 7.2 milligram semaglutide. So in future, very soon, we will get a approval to go up from 2.4 milligram of Wegovy to 7.2 milligram. And then we will not be discussing tirzepatide versus semaglutide. Now, if you look at the broad spectrum, issues with semaglutide starting from 0.25 milligram to 0.5 to 1 to 2.4 to 7.2, across these trials, you can see the benefit is happening across the board, not only in terms of CB risk reduction, but if you look at the heart failure trials with a step heart failure trial, with preserved ejection fraction trial in people with obesity or in people with diabetes. So that's the entire summary of semaglutide from oral to injectable to 1 milligram to 2.4 milligram to 7.2 milligram in the step-up trial. Ladies and gentlemen, if you look back into the summary of semaglutide today, and if you look at the level update currently of semaglutide, you hardly find any molecule anywhere in the pharmacotherapy of diabetes, obesity, cardiovascular disease. Look at the level update. So starting from the Ozempic 0.5 to 1 milligram through the Sustain 6, semaglutide has been approved to be used in patients with diabetes with established cardiovascular disease. If you go through the flow trial, you have got a level update that if you have got a patient with a diabetic kidney disease, the only GLP-1 to be prescribed to prevent the hard renal endpoint data currently is with semaglutide 1 milligram. Oral semaglutide version, as you all know, called Rybelsus, has also got their level update through the SOUL trial. Remember, in the SOUL trial, in patients with type 2 diabetes with established cardiovascular disease, semaglutide reduced the 3P by 14%. And that was primarily due to reduction in non-fatal MI. So injectable semaglutide 1 milligram, which is roughly equivalent to 14 milligram of oral semaglutide, has got both the data. Once you give orally, you get the MI benefit in the SOUL trial. Once you give injectable, you got a stroke benefit through the Sustain 6 trial. The moment you push up the dose from 1 milligram to 2.4 milligram, that is with Wegovy, in select trial in people with obesity, there was a 20% reduction in composite of 3P with semaglutide 2.4 milligram. And as you all know, in the Essence trial, in patients with MASH on 15th August 2025, semaglutide is the only GLP-1 to receive a level update in people with MASH, regardless of diabetes, regardless of obesity. So this is the 5 indication with a different variation of semaglutide, starting from injectable semaglutide 1 milligram to oral semaglutide 14 milligram to injectable semaglutide 2.4 milligram. These are additional colors, scale, whatever you would like to say, beyond body weight and HbA1c reduction. To summarize the entire presentation, both of us spoke on the data, people thronging to take Ozempic, as I said, from Karan Johar to Vidya Balan, from Elon Musk to Serena Williams, why people are shifting from this, GLP-1. Just to summarize the story in terms of cost perspective, also I would like to tell you, when you look at the innovator drug and their cost, painfully I need to show this data. I don't want to compare the cost in front of audience. It might look little commercial, but as a clinician, it is our duty to know, when it looks at the comparator, how much is the cost worth of when you are looking at GLP-1, either Ozempic or Wegovy or tirzepatide, that is Mounjaro. Entirely your choice to choose between these molecules, but do use this molecule when you get a patient with diabetes with or without obesity. Thank you very much for your patience listening.
Thank you.